document and what will be its vital role in supporting those affected by the devastating impacts on their mental health of suffering from a group of 20 or so neglected tropical diseases. I'd like to congratulate the many organisations and individuals who've devoted so much time to bringing this excellent document to fruition, and thank those organisations and individuals who've committed to adopting the recommendations in this document. This represents collaborative partnership at its best, drawing on the skills and experience of many individuals and organisations committed to improving the quality of life of millions, but also strongly influenced by the experiences of those living with these conditions. Now, I'd like to reflect how we got here. The starting point for me was across the road about 20 years ago, meeting up for lunch, completely unorganized and by chance, with Professor Barry Munslow, who was Professor of Politics in the university and who was running our course on humanitarian assistance. And with him was a student called Lizzie Litt, who was a high-flying fourth-year medical student across the road in the medical school. And she wanted to do something on NTDs. And it struck me at the time that nobody had tackled the issues of mental health and NTDs. One of the first publications I ever came across was by Professor Lambo, distinguished Nigerian psychiatrist, who worked on sleeping sickness in the 1950s and actually signed the form which allowed me to become a member of the WHO staff in 1975 when he was Deputy Director General. So that goes back a bit. But what I'd experienced from family situation was with chronic health, the impact of anxiety and depression is there all the time. And we put Lizzie Litt onto a dissertation on mental health and NTDs, scanning the literature and so on. And that dissertation resulted in a paper in Trends in Parasitology, which ignited wider interest. A co-author on that paper, Baker, who many of you will know, who had been a PhD student of mine working in the Dominican Republic, and previous to that, a volunteer in Vanuatu working on the LF program. And Maggie had an experience, a family experience of a caregiver of one of the members of the family. And she contributed to that paper, looking from the perspective of caregivers and the burden that they suffer in looking after somebody with disability. That's the start. Then, over time, the school was given research money following bids to what was DFID, but now FCDO, for the Countdown program in 2014. And this led to many partners joining LSTM in looking at these issues. But what is not recorded by Laura and the team was that the first proposal to FCDO or DFID at the time included mental health based on the work we were doing, but that was not funded. It was only latterly that FCDO decided to put a mental health component into the research, which led to the work in Liberia, the subsequent redress program, and provided a platform for Laura and her colleagues, which has now resulted in those projects, the Peace of Mind and Imagine projects, which are now ongoing. I think it's really important to emphasize that that partnership received one of the highest accolades in UK higher education by being awarded in 2024 the Times Higher Education Award for International Partnerships. That is an accolade sought by many, but so few get it. So parallel to this, during the 2010, 2012, 14, 15, I was frequently in contact with colleagues in Geneva, Lorenzo Savioli, and he put me in touch with the people in the mental health and substance abuse department in Geneva. At the time, it was Taran Dua. And Taran Dua put me in touch with a health economist in California, Tan Tom. And with Tan Tom and Charles Mackenzie, because we were working on LF, we started to explore what the burden, the true burden of LF was, taking into account the mental health publications which had taken place. I think there were 5 or 6 studies from Haiti to India and so on, where the anxiety and depression had been quantified. And using those figures, we came up with the figure that, on a conservative estimate, the global burden of filariasis attributable to mental health conditions was some 5 times, this is a conservative, more than had been previously estimated by the global burden of disease people. At that time, I actually went to see Vikram Patel, who was one of the most distinguished mental health experts, supported by the Wellcome Trust as a principal fellow, who then, I think, during went to Harvard, and asked Vikram Patel in the London School, do you know anything about NTDs and mental health conditions? And he looked at me and said, no, never thought of it. This is the world's leading expert in mental health. We then started to think widely, and I was generously supported by Sanofi Aventis because of their interest and support for kinetoplastic diseases, leash and trips, Chagas and so on. And those support enabled us to study the burden in Buruli ulcer, African sleeping sickness, and critically, cutaneous leishmaniasis, because I found an excellent 4th-year student who effectively volunteered to look at the burden of cutaneous leishmaniasis, Freddie Bailey, in the settings of a disease which can be acquired early, gives unresolvable lesions, very often on the face and hands, because of the way the sandflies bite, which are unresolvable, but cause no mortality, but live with that individual throughout their lives. So we then started to look at the critical factor in generating DALI burden, and that's years of life lived with disability. Now, the dates which are attributed to NTDs by the Global Burden of Disease Study people are trivial. But if you're living with anxiety and depression, mild depressive illness has a disability burden of 0.2, moderate is 0.4, and severe depressive illness is 0.6. If you put those together with the years of life lived with a disability, using the mortality figures from different parts of the world, you get an enormous burden of DALIs. So that was the direction of travel that we went on. Now, LSTM, and you've heard from Giancarlo, now has a big portfolio of studies in this area, and it's great to welcome Julian Eaton, who's been a great supporter of my view and my views over the last few years, to join the school to take this area forward. But here's the problem. The mental health burden is missing from both sides of the equation. What do I mean by that? Mental health calculations for NTD associated issues, stigma, disability, and so on, are not included in the DALI burdens published by Seattle, the Global Institute for Health Metrics, nor are NTDs in any of the equations from the mental health literature. If you look at the documents from distinguished authorities like Vigo, Saxena, Thornycroft, etc., Arias, there is no mention of NTDs in the global burden of mental health in the literature. So we're missing out on 2 fronts. Now, this is a classic of silo syndrome. We all talk about being in silos, but this is a huge silo where no side is recognizing the burden of the other. Some further points seem to me to be relevant, particularly in relation to this document. I've been fortunate to travel around the world over a period of several decades, but I also got a lot of these documents in my study. I suspect we all have. One of the commonalities is that WHO puts together these beautiful documents, but they lie on shelves or stacked on shelves, gathering dust, never opened, and they actually are wasted. People don't actually have the time to consult them. But actually, this package is too important. This must never be consigned to shelves and gather dust. It must be actively accessed. It must be promoted. It must be implemented by ministries of health and partners worldwide. Those who've contributed to this and put the energy into making it such an important document, it's got to become a living guide, not a forgotten text. And I see some unfinished business in this area, particularly related to NTDs. And particularly across the road, you've got the biggest collection of venomous snakes in the country, probably in the world. Snake bite envenoming is, whilst the deaths from snake bite envenoming are around 100,000 persons per year, probably the highest mortality of an NTD around. 400,000 to 1 million snake bite envenoming take place in a year. The mental health problems of those envenomed are not addressed, and there is a huge burden which needs to be addressed. Those people who are suffering from amputation and so on as a result of snake bite envenoming have a real problem of mental health, stigma, and disability. Now, I've mentioned the lack of information about mental health and NTDs in the mental health literature, but the mental health professionals pre-COVID estimated that the global burden of mental health globally was 3 times more than the original estimates from the Global Burden of Disease study. So we have a big problem here because mental health problems have increased hugely since COVID. And we see the mental health problems which are being generated, particularly in younger people, from the use of social media. The other thing I think which is important here is the geographic issue, and I make a point about this, particularly in relation to LF and Onco. The issue is this: the access to communities in the tropical rain belt, from Manaus through Eastern Congo to Papua New Guinea. Access is critical, particularly in areas of high montane and mountainous regions. One gap also, which I think is really seriously understudied, is schisto and the mental health morbidity associated with its clinical problems, as well as female genital schisto, which is hitting the headlines so vigorously. Now, we can't also forget the mental health problems which caregivers suffer. And I think it's really important to recognize the economic, social, and educational impact that it has on caregivers. Also remember, the African Development Bank has projected that by 2030, 50% of the population of sub-Saharan Africa will live in urban settings and peri-urban settings. And this is going to create huge problems for access to appropriate services. So I'm coming to the end. This is a call to action. This essential care package is not the end, as many documents are. Certainly the authors think that once you've produced a document, it's the end. This is the beginning. The NTD community must maintain this momentum, advocate for the resources to address those furthest behind. Our traditional aid model, which pertained till January last year, has been completely disrupted, as we know, and we all have to rely on ourselves. However, I think there are 3 intertwined connections and commitments here. Bill Gates' credo, every life has equal value, and universal health coverage that says leave no one behind, and the UN Sustainable Development Goals, where achieving NTD targets is a litmus test of poverty alleviation. I think we must turn these aspirations into reality through this document. And this document is the key to NTD success. So thanks again for your time. I hope you have great deliberations. It's lovely to meet you, and thanks again, Julian, for the invitation.
Very much, David, for talking with us today. It's a real honor to have you here. We're going to move on now to some of our other invited speakers. So first of all, I'd like to invite Jonathan King to come and speak. Jonathan is a scientist and lead at the WHO Global Program to eliminate lymphatic filariasis. Welcome.
Thanks, Julian, and thanks, David, for sharing that history. I'm also going to start with a little bit of history that you're very well aware of. And 25 years ago, WHO launched the global program to eliminate lymphatic filariasis. And as you showed pictures, an NTD that's noted specifically for human suffering, social stigma, and financial loss to the whole society. The program was and remains based on two pillars. The first was to stop transmission through mass drug administration. And secondly, to alleviate suffering among persons already affected by the disease. And there's been tremendous progress in Pillar 1, with more than 943 million people that have received treatment through MDA campaigns in all 71 countries where it's required. 21 of those countries have met the criteria to be validated by WHO as having achieved elimination as a public health problem. The second pillar has relied on delivery of effective interventions known as MMDP, morbidity management and disability prevention, to provide care for the physical manifestations of LF. And this includes surgery to cure hydrocele and simple measures such as a daily hygiene routine for the affected limbs to prevent acute attacks, to improve the condition of the skin, and to prevent progression of disease. Yet only about half of LF endemic countries can give a national estimate of the number of people with lymphedema and hydrocele. And less than 20 report providing care every year to WHO. You may have heard some statements like the following from people with LF. If you've been working in this field, you had some quotes that you shared. No one wants to have me around. If someone looks at me, once they see, they turn their head. I have a son and a daughter, but they don't stay with me or support me. I stay alone in my sister's house most of the time. I stay in my room. So while effective care may be available, people with LF often are afraid to even seek care due to stigma, and that stigma at home, in the community, and in the healthcare system. And there are probably multiple reasons why the progress in the second pillar has lagged, but one aspect is undoubtedly due to stigma. And today I'm hopeful that this essential care package addresses to address mental health and stigma will enable NTD programs to remove these barriers to accessing care and expand the focus of care beyond just the affected limb to the overall well-being of the person. And I'm grateful for LSTM. I'm grateful for the DMDI members, that's disease management and disability inclusion. Working groups supporting WHO to develop this essential care package. And I'm also grateful to my colleagues in the Department of Communicable Disease and Mental Health for taking the lead role in that collaboration. For the past few days, I've joined the DMDI meeting, and I've wondered what would progress in GPELF, that's the global LF program, what would it look like today if MMDP would have been the first pillar and had nearly equal investments as has been generously and successfully poured into MDA, preventing millions from disease. Could have addressing MMDP first in endemic communities, created a more effective MDA strategy. Potentially, this would have raised coverage and required less number of rounds to reach the target infection thresholds. So C.S. Lewis is attributed to a quote that says, "You can't go back and change the beginning, but you can start where you are and change the ending." So I'm hopeful that the uptake of the essential package of care will help reprioritize Pillar 2 of the global program to eliminate lymphatic filariasis, recentering focus on more holistic care for people who will remain with LF disease long after the risk of infection has been eliminated. So doing so can change the ending, putting us back on track and increasing our confidence that we've also had similar success in alleviating suffering. Thank you.
Thank you very much, Jonathan. Now it falls upon me to take you through this document. I hope that very quickly you will be able to have a look online, and also we'll have physical copies going out around the world as well. This document was developed in order to do two things. First of all, to make practical and available the principles in a document we'd previously developed with WHO called Person-Centered Care for people with NTDs. So it seeks to make this work available to the people who are doing frontline work in countries, which is what matters more than the theory, putting it into practice. We borrowed a lot from important principles and ways of working that other fields have already used effectively. Any good framework for practice in the field involves a pyramid, occasionally a cycle, but usually a pyramid. And we want to make sure that we have the right level of care, not to overly medicalize for people who have a degree of distress that can be resolved and supported with their community members or the family, but going right through to providing proper, appropriate specialist care for the people who need that. Within the ECP are roles that different people need to play. Very importantly, we're crossing some of those silos that David talked about. We're going, for the first time in many cases, to bring together people who traditionally work in mental health and well-being and people who work in neglected tropical diseases, to help them to more effectively work across those traditional silos. We're going to work out what people should be doing, or clearly identify what people should be doing at different levels of that pyramid system that I showed you a second ago. Part of that is recognizing what needs to be done by the mental health community, partly what needs to be done in relation to the stigma work that is much more community based, and that's going to be done by community health workers as well as people in primary care and others. What we've realized from other similar kinds of packages is that it's okay to have an overarching guide to how to do things, but there's lots of really practical tools that are needed as well. So within the essential care package already, and some of our work over the next few years is going to be making available those practical tools. So things like, how do you work out what it costs in a district to run this program? How do you accurately count the number of people with need in your community and set up services that match that level of need? And then how do you monitor how well you're progressing with your work? Do you need to change emphasis and do things in a slightly different way? So what are we going to do next? And I just want to point out these very beautiful pictures. It's the document's been put together really thoughtfully and sensitively. And some of these pictures have come from the really wide consortium that contributed to this work. We've been meeting, as Jonathan said, this week to think about what to do next. We want to make sure that the package is well known by the people who should have it available to them. That's national program managers primarily, but also the really strong civil society sector that works in this area. We need to find enough resources, financial resources, and people trained appropriately to deliver it well. And these traditional routes of funding have changed recently, but there's a real commitment to moving towards more domestic financing, and we're going to really be exploring that. And then adding to the resources that we really need to carry on doing the work and making sure we're putting the tools in the hands of people who really need it. And that might include training online and things as well. And we're going to be doing some research to support that. We've had a really good relationship with the research community and the implementation community. We want to maintain that. So here is a QR code. Please have a look at the resources on both the WHO website where it's housed, and also Info NTD, which has a lot of the surrounding additional resources linked to stigma and NTD work with mental health as well. So we're going to move on now to hear, first of all, from a person with lived experience, Emmanuel Zeze from Liberia, involved in some of the research that we're doing here, who's being interviewed by Rosie McCullum. So I'll play this video now.
Thanks so much for joining me today, Emmanuel. I was wondering if you could just start by introducing yourself.
Thank you for the opportunity given me today to articulate on behalf of myself along with persons affected with negative tropical diseases in Liberia. Having said that, I'm Emmanuel Zeze, a person that knows Liberia also and got treated from the conditions. I'm from Lofa County, Liberia.
Thanks, Emmanuel. So could you tell us a little bit more about your story and about how having an NTD affected you?
So the NTDs affected me in many ways. NTD caused isolation on my life. NTD caused stigma on me. So NTD delayed my level of education, my time. So NTDs caused my social life to be reduced.
Sorry.
So NTDs cause a complete society acceptance. So society could not accept me because of my deadly condition that I had. So society could not accept me, community could not accept me, stop my social activities, which of course every human being should have right to, but because of the condition, my social life were seized, and complete isolation was done in my life and nearly caused disability to me.
Thank you so much for sharing that with us, Emmanuel. I'd like now to ask, what happened in Liberia to improve mental well-being and to reduce stigma for people with NTDs?
Okay, so thank you. So in Liberia, there have been several things that have been initiated to improve the mental well-being and to reduce stigma for people with NTDs in Liberia. That is, one thing was we know that NTDs are being focused on health workers. So for the initiative of training health workers to screen and to provide basic psychosocial support to persons affected has been a great milestone done by the Ministry of Health through the Redress Project, and also establishing a peer support group.
And how did these activities impact on you and impact on your well-being?
So thank you very much. So these activities has caused positive impact and well-being on my life, especially about the access to mental health supporting through the Ministry of Health and partner support, especially with social stigma that have been on us, that because of our condition, we are being stopped to social life. So with these activities that are being implemented by partners in the Ministry of Health at NTD program, so these things have helped us to have access to support, especially even to mental health support, and also reducing social stigma, so fostering community acceptance.
Thank you very much for Rosie for organising these interviews. We've now got an interview with Emerson Rogers, who's a case management coordinator in the NTD program in Liberia, who's speaking with Joseph Koi, who's the mental health program manager at the Ministry of Health. And they've really been a great demonstration of how these two ministries have been working effectively together in this area. And just to mention that in the room, and I think you can hear online, there's lots of pinging. And that's all the people sending hearts and thumbs up. So, I'm just going to move on to the next.
Thanks so much for joining me today. I'm joined by two colleagues who work with the Ministry of Health in Liberia. So to start us off, I'd like to just ask you and invite you to introduce yourselves. So
Thank
Emerson,
you very much, Rosie. My name is Emerson Rogers, and I serve as the National Coordinator for Case Management of Neglected Tropical Diseases of Liberia, Ministry of Health.
I'm Joseph S. Quick, pharmacist by profession. I work for the Ministry of Health. I also serve as training coordinator for the mental health program at the Ministry of Health.
Emerson, my next question's for you. Please could you tell us what has the benefit been for the NTD division by integrating mental health and stigma reduction within care for people affected by NTDs?
Thank you, Rosie. There are a lot of benefits we've experienced since we've integrated with the mental health division. We have been implementing the integrated approach of neglected tropical diseases for several years, like 6 years now. And we've come to realize that people affected by NTDs are usually stigmatized and discriminated, either by their family members, immediate family members, or community members, or other workplaces. And some of these people usually come down with some suicidal thoughts and are down with depression and anxiety. So we have been addressing the NTDs components of that illness, but we come to realize that they need psychological support. They need to be counseled. They need to be removed from the state in which they are, of being isolated, having internal stigma or external stigma by their neighbors. So we saw the need that we needed to integrate with the mental health division. And since we've done that integration, we have come to realize that when we are approaching a patient that presents at a health facility, we are approaching them holistically. We are not leaving out their mental status, but we are addressing both the NTDs condition and that of the mental issues, because we have this tool that is used by the mental health clinicians that the clinician use at the point of diagnosis or assessment to assess as to whether the patient, the NTDs patient before them is presenting with mental issues. And if they reach the score that require mental health intervention, that patient is immediately referred to the mental health clinician for intervention. So the patient definitely receive a holistic care at that level. And this is one of the benefits we've really experienced as a program, as an NTDs program in Liberia at the Ministry of Health. And we've come to realize that our patients are responding well because they feel wanted, they feel that they are part of society again, compared to, at the time where they were not, we have not integrated NTDs with mental health. But now that they are receiving psychosocial support and knowing fully whether they are part of the society, they feel wanted at all times. So this is one of the benefits, giving people their life they have lost in the past.
Yes.
Okay.
Yes.
Great. So, Joseph, what lessons have you learned by integrating NTDs, mental health, and stigma reduction?
So, like Emerson said, all of what we do at program level, all geared towards patient care. Holistic care should be provided to the patient. So, capacity building for healthcare, for primary healthcare providers who are not specialist mental health care providers is very essential. And having trained the primary healthcare provider, we learned that it is cost effective because they are already paid by government and they are already screening patients. So training them, we build their capacity to provide services for persons who are affected with NTD and other conditions.
So what practical advice would you like to share with any Ministry of Health that's planning to introduce the essential care package to address mental health and stigma for persons with NTDs?
Okay, so my advice to Minister of Health all over the world is government ownership, Minister of Health ownership. The programs under the Minister of Health, the mental health program and the NTD program should firstly collaborate and work together. The essential care package is based on practical and proven evidence of some of the things that we did in Liberia. Involvement of family members, involvement of community members, influential group, persons affected, and the list goes on. And the essential care package actually stress local resources, domestic resources. And that is very important because it will be sustainable if the government owns it and implement it.
And integrating with mental health is very key. And I would like to emphasize this to all Ministry of Health in Africa and around the world. Please do not overlook integration of NTDs with mental health.
Thank you. We are very grateful for the collaboration we've had with many countries. Actually, Liberia has been where much of the research has happened, but actually there's many countries that are really taking forward these ideas, and it's the learning from countries that really come into this essential care package. We're privileged now to have 3 online speakers from organizations that have been very intimately involved in this process, and I think will be even more important as we seek to roll it out in countries. First of all, Mark van Ommeren from the World Health Organization, who leads the Mental Health and Substance Use Unit. Chido Rafa Madzvamutse from the WHO Afro mental health advisor, and Mohammed Abdulaziz, who's the Director of Disease Control and Prevention at Africa CDC. So I'm going to hand over now to MHIN, Gagana Manilova, who's going to take us through those interviews. Thank you.
Thank you, Julian, and hello to everyone listening to us online via the live stream and in the room. I will facilitate our online speakers on behalf of the Mental Health Innovation Network, which is hosting this webinar, a community sharing resources and ideas to improve the lives of people with mental, neurological, and substance use disorders. You can find us online, and we have also shared the Essential Care Package launched today, published by our partner, the World Health Organization. Speaking of WHO, our next speaker is Mark van Ommeren. Mark, you have the floor.
Thank you. Can you hear me? So I just checking that, yes. Sorry that I could not be there with you in person because the executive board is ongoing. Otherwise I would be there with you. Thanks so much for the Liverpool School for organizing this and for also the launch. Look, is really, really well done, and learned so much from the videos and from the involvement, particularly the videos from the stories from Liberia, so helpful. Very pleased that we launched this Essential Care Package today. It is for policymakers, program managers, providers, communities, from the national to the frontline settings, for people affected to support where they live. So, over 1 billion people around the world have NTDs. Over a similar number around the world is estimated to have mental health conditions. And as may be clear from today, many people have both. That's because having an NTD is an enormous, powerful risk factor for developing mental health problems. As we've seen in the video, people living with NTDs face stigma, and as a result, discrimination and social inclusion, causing additional distress, further elevating the risk for depression and anxiety. This is, of course, particularly the case where the NTDs have very visible manifestations. So there is no way, no path to ending the suffering from people with NTDs without addressing mental health and stigma. And similarly, there's no path of addressing the mental health for all people if we do not properly consider people affected with NTDs. This is a consolidated essential package, evidence-based. It's practical, full of concrete guidance. It is for ministries of health and NTD programs. And it is really helpful, and it has all the contents to embed mental health and anti-stigma actions within national NTD strategies and budgets. And it gives guidance what the mental health and primary care providers can do from the clinical and psychological interventions and psychosocial interventions, but also guidance for community workforce, community health workers, peer groups, and NGOs to reduce and address stigma and social exclusion. It's all evidence-based, as one would expect. And for the stigma, the stigma strategies that included are the most evidence-based anti-stigma strategies, which are all based on social contact interventions that reduce, because they are very effective in reducing the stigma by contact between those who stigmatize and those who are stigmatized. Really, it's very helpful, whether it's for NTDs or for other stigmatizing health problems. It has also, this guide has guidance also on implementation, for planning, supervision, and quality control. This package reflects collaboration between the NTD community and WHO, and many inputs of partners and persons with lived experience. And we asked today for all countries, donors, civil society, professional bodies to join us in implementing it at scale with urgency. Together, we can ensure that the promise of NTD programs includes mental health, and the promise of mental health includes helping people affected by NTDs. I really want to thank the members of the NNN group of DMDI, specifically I'm referring to the NTD NGO network group on disease management, disability, and inclusion. I gratefully thank Julian, not just for organizing today, but for all his work and advocacy in making this happen. And Rosalind McCollum, from the Liverpool School of Tropical Medicine, pushed for the work and did much of the work. But also I want to acknowledge Akeri Mahmood from KCL and my colleagues Aisha Malik, Nirja Chowdhury, and Jonathan King. And of course, in the steering group, many important organizations there, including the Netherlands Leprosy Relief, in India, CBM Global, Leprosy Mission, Carter Center, Lepra India, Leprosy Mission Nigeria, and others. Thank you so much, and let's make sure that this document gets implemented.
Thank you so much, Mark. Now, over to Chido Rafa Mazvamute, who is the Regional Advisor for Mental, Neurological, and Substance Use Conditions for the WHO African region. Chido.
Thank you so much, Gagana. I'm very pleased to join this launch on behalf of the regional office, and greetings from Brazzaville. And in Africa, this is where the burden of neglected tropical diseases and mental health conditions intersect acutely. Approximately 40% of people worldwide who are affected by NTDs live in the African region, affecting over 580 million people, largely in poor, rural, and marginalized communities. At the same time, nearly 150 million people are affected by mental health conditions, and services remain severely under-resourced, poorly integrated into primary care. This new essential care package arrives at a critical moment, offering practical, scalable advice and guidance to address both realities together. In many African countries, NTDs are not only conditions of infection, they are conditions resulting in long-term disability, disfigurement, stigma, and social exclusion has already been highlighted. Conditions such as leprosy, lymphatic filariasis, onchocerciasis, schistosomiasis, and norma often lead to chronic suffering, disrupted education and livelihoods, and profound psychological distress. Africa faces the highest burden of norma, a gangrenous disease of the face and mouth, affecting mainly children, which carries a very high fatality rate without treatment, but also leaves survivors with lifelong facial disfigurement, disability, stigma, and discrimination. Evidence from across the region shows that stigma delays care seeking, weakens treatment adherence, and deepens mental health challenges, particularly for women, children, and people living with visible NTD-related disabilities. Yet mental health support has historically been absent from NTD programming, while NTDs have remained invisible in mental health programming. This care package closely aligns with the WHO NTD roadmap, which calls for person-centered integrated care beyond infection control, and the WHO regional framework for mental health, which encourages the importance of decentralization and integration of mental health into primary care and community-based care in a person-centered approach. It also complements emerging regional work, including collaboration with Africa CDC and partners to embed mental health and well-being into NTD programming. This publication is especially relevant for Africa because as mental health systems in Africa remain underfunded and overstretched, integration with existing NTD platforms is not optional, it's actually essential. The package is designed for low resource settings, emphasizing non-specialist task sharing interventions that can be delivered through existing platforms. It's also focused on stigma reduction, not only clinical care, recognizing that stigma is one of the strongest barriers to access and recovery in NTD endemic communities. It is grounded in lived experience, encouraging countries to work with people affected by NTDs as partners, as peers, and as advocates. It is adaptable and open access, allowing ministries of health to translate, contextualize, integrate the package into national NTD master plans and mental health strategies as they see fit. For countries in the African region, implementation can begin immediately by embedding mental health screening and brief interventions into routine NTD screening during case detection and treatment and follow-up, training community health workers and NTD focal staff to recognize distress and provide basic psychosocial support when needed, and then referring. This really will help to close the treatment gap, particularly in rural areas. It links morbidity and governments can also link morbidity management and disability services with mental health and psychosocial support so that long-term NTD impacts are no longer neglected. and implementing community-level stigma reduction, including peer groups, family engagement, and contact-based education. Monitoring outcomes is also important, things like well-being, functioning, and social inclusion, not just infection metrics. So just calling to the ministries of health to really make use of this package to bridge NTD and mental health programming, ensuring that mental health is costed, planned, and monitored as part of NTD strategies. And to partners and donors, we request and we kindly request a greater investment in an integrated person-centered models that address both physical and mental suffering. To implementers, to civil society, may you continue working with communities to challenge stigma, support recovery, and amplify the voices of people with affected by NTDs. WHO Afro stands ready to provide technical assistance, adaptation support, and regional learning platforms to accelerate uptake. This package is not just a technical document, it is a statement of values. It affirms that in Africa, eliminating neglected diseases must also mean addressing neglected suffering. By integrating mental health and stigma reduction into NTD programming, the African region can lead the way in delivering truly person-centered and equitable care. Thank you very much to the organizers, and back to you, Gagan.
Thank you so much, Chido. Now welcoming Dr. Muhammad Abdulaziz, Director of Disease Control and Prevention at the Africa CDC. Dr. Muhammad, you have the floor.
Thank you. Thank you so much. First, let me thank Liverpool School for inviting Africa CDC to this very important discussion. Today, we are here to address a critical issue, the intersection of mental health and neglected tropical diseases. We will discuss the essential care package designed to combat stigma and mental health challenges faced by those living with NTDs. In Africa, when we talk about NTDs, we know that we're talking about, like Chido said, a great percentage of our population that suffers from this chronic debilitating disease. Chido has already mentioned many of the things I wanted to say when it comes to the epidemiology of this disease on the continent of Africa, but it is quite instructive that when Emerson and earlier speakers spoke, he talked about how we can ensure that this essential care package is integrated in a way that we can be able to deliver it and make changes on the continent of Africa, especially in its implementation. So the individuals with NTDs frequently experience stigma, which exacerbate their suffering and isolate them from their community. The stigma contributes to significant mental health issues such as anxiety, depression, and low self-esteem, which we have had. And significantly, it's also a significant economic burden and cause loss of productivity. We in Africa CDC, we understand and this effect, and let me remind participants of this meeting that at the Africa CDC launched the second strategic plan, where the pillar 1 is the integrated health system for the prevention and control of high burden diseases, which include NTDs. So it's quite instructive to hear many participants today talking about an integrated approach, integrating mental health care into that of neglected tropical diseases, and ensuring that we have a whole of society and whole of government approach to managing this intersection between mental health and neglected tropical diseases. Julian earlier talked about how do we operationalize this essential care package, and I had Mark and Chindo talking about ensuring that we integrate this into the national programs so that we do not create a vertical system. And this, for me, is the key to ensuring this happen. I already spoke about the Africa CDC strategic plan, but we also want to let you know that going forward in Africa CDC, in the program I lead, we have the Africa CDC Mental Health Leadership Program that has the a Kofi Annan Fellowship that looks at leadership at the highest level for mental health. We have the FETP program that looks at integrating public health competencies and skills to mental health challenges, and a short course and people with lived experience pillar, 2 different pillars, but that wants to use advocacy and applying that to mental health challenges. I want to say very clearly that we will henceforth look at how we can use this intervention, this flagship program of Africa CDC, to support the rollout and integration of the essential care package for mental health and NTDs among our member states. For instance, we will, in the short course we do, we will look at how we can introduce a team that speaks to that speaks to the pyramidal structure of the delivery of the essential care package, where most of the intervention is going to be in the community and at the family level. How do we, among the healthcare workers that we and the NGOs and CSOs and people with lived experience that we are working with, encourage them to pick on this and support our member states in the implementation of these essential care packages in the programs across the continent of Africa, so that we can really have a multi-sectorial approach, a whole of government and whole of society approach to this care. By addressing both physical and mental health, we can improve the quality of life of individuals affected by NTDs and reduce stigma in their community. I urge all stakeholders to implement the guidance provided in the essential care package, and together we can create an environment where mental health is recognized as a critical aspect of care for individuals with NTDs, reducing stigma and fostering community support. May I end my intervention by saying Africa CDC is also working with partners, including the Liverpool School, to develop or to implement a package of intervention when it comes to NTDs and mental health. In Africa CDC, we have a center where we have 2 divisions. We have the division for the NCDs that I lead, and then we have another division for infectious disease. And we're really working very closely with partners to see how we can really intervene to ensure that NTDs and mental health gets a fairer look in our member states programs, and we hope to work with everyone here moving forward. Thank you, and back to you.
Thank you so much for the impactful words to all speakers. Now back to the room at Liverpool School for closing remarks. Julian, over to you.
Thank you very much. And actually, I'm just going to hand over to Giancarlo for any final thoughts, but thank you for attending, everyone.
Well, thank you, everyone. It leads me to close the meeting. I just wanted to, again, just congratulate all the people that have pulled this essential care package together to this point. We've clearly heard today a call to action. Everyone has made the point that this isn't just a document, it's the start. We've heard a call to action, and I've blown away by the speakers and contributors. The energy and passion that they have gives me great confidence that this will indeed be adopted globally. So I wish everyone the best of luck in that endeavor. And again, congratulate everyone up to this stage and the best of luck going forwards. And thanks again.